So good morning, everyone. We're going to start our next debate. I hope our RDS debate will be more challenging than the census debate. So we'll introduce our speaker, Prof. Michael Luisi. He's a professor, critical care medicine, bioengineering, cardiovascular disease, and anesthesiology at the University of Pittsburgh. Dr. Day1 C2 Session from the University of Montreal, Quebec, Canada, and completed his postgrad in internal medicine, residency, and pulmonary fellowship training at Stanford. And also he had advanced physiological training at Johns Hopkins Medical Institute, Baltimore. He has published over 400 peer-reviewed manuscripts, edited 27 textbooks, and mentored over 40 postdoctoral trainings.
Then we have Prof. Arthur. He is a professor of medicine, surgery, and biomedical engineering, and past vice president at St. Mike Hospital. A hospital I didn't work in. It was my bad luck. He was director of the respiratory division, as well as the director of the interdepartmental division of critical care medicine at University of Toronto. His research has been highly translational, focusing on basic discovery, including importance of atelectic trauma, discovery of biotrauma, ventilation, and ventilator-induced pulmonary fibrosis. Dr. Slutsky has published more than 750 original papers, 70 books, chapters, and many randomized controlled trials. And we have Dr. Lorenzo, which I had the privilege to work with him many times. He's an intensive care attending at Toronto General Hospital, associate professor internal medicine at the University of Torino, and in adult critical care medicine at University of Toronto. Lorenzo's main academic interests focus on the application of innovative strategy to prevent the injury induced by invasive mechanical ventilation, including extracorporeal life support strategy in patients with acute respiratory failure and lung transplant. And we have Prof. Fikri. Prof. Fikri is a professor at the Faculty of Medicine of Monastir. I hope I'm pronouncing it well. And the head of the ICU there. He has held several responsibilities at the national and international level as a president and vice president of Scientific Society of Critical Care Medicine, including Tunisian and French ICU, Pan-Arab Critical Care Medicine. His main area of scientific research concerns COPD exacerbation, non-invasive ventilation, and high flow. So we'll start our debate, or our, let's say, pressing question. And basically, me, myself, I face the question every day at the bedside. And sometimes even I argue with my colleague, what to do. So, we're at the bedside, we're having patients with severe RDS, and the ongoing question, do we look at the driving pressure, or is it the plateau is more important? Because we were in many situations where, if you think, the plateau is all that not matter, and we don't look at the driving pressure. And as long as my plateau less than 30, then my patient is safe. But, we know with more evidence and more research that the lower the driving pressure, the better the outcome, the less, the power in the lungs. So we need to convince people here that the driving pressure matter more than the plateau.
So maybe I'll start. If you look at the randomized controlled trials, the ARDSNet study had a plateau pressure of 30, and so that became sort of the standard. But I think the driving pressure is actually much more important. And the study by Amato, published in the New England Journal in 2015, showed that when you looked at plateau pressure versus driving pressure was the key driver. And I think the reason for that, it's worthwhile thinking about why that is. And I think the reason is that if you think about driving pressure is the tidal volume divided by the respiratory system compliance. And the respiratory system compliance, really, what people wonder, why is that important? Well, it basically tells you the size of the lung, and that's what's important. So you're normalizing the tidal volume for that stiff lung. So I think that the evidence suggests that driving pressure is more important. There haven't been any trials that have proved it. There are some trials ongoing, so hopefully we'll have a better answer going forward. So I think it's driving pressure that's more important. And it's actually especially important when patients have very stiff chest wall, let's say with ascites, because there you can have the plateau pressure greater than 30, 35, even higher, and yet you're not causing injury because the lung isn't really expanding much. In that case, the driving pressure is a much better indicator of the severity of likelihood that the patient's going to die. So I think the driving pressure is much more important. I'd be interested to hear if there's some debate about that.
Yeah, I want to argue a little bit. So
Good.
For sure, we need to look at driving pressure and plateau pressure, but the question is also what we should target. So I think we should target plateau pressure because the evidence at the moment suggests that if we target plateau pressure and lower plateau pressure below 30 as indicated, and then depending on the patient, maybe even lower, we improve outcome of the patient. We're waiting.
So what do you do? What do you do with a patient who's got a stiff chest wall, who's got massive ascites? They're going to have a plateau pressure of 30. If you look at the chest X-ray, the lung is small, so they're not at risk for ventilator-induced lung injury.
Yeah, and so in certain cases, sometimes we measure.
Okay.
Yeah, no, but we measure. I still like to have, if it's possible, plateau pressure less than 30. The problem is that if it's impossible to achieve that target, what to do?
Well, it may not be impossible, but you may affect gas exchange, and you're going to get much higher.
Exactly. It depends on how much. What's
Yeah.
the cost of maintaining the plateau pressure within that target? We have another question. So if we look at the driving pressure, because the paper by Marcelo Amato is very interesting, very nice, and show that driving pressure within the first 24 hours from diagnosis associated with outcomes, strongly associated. So we should look at the driving pressure only the first day and then forget about it, the rest of the 10, 14 days, or we should look at every day. And then should look at the static driving pressure, or just like my colleague Martin Erner suggests, maybe a dynamic driving pressure.
Yeah. I don't think there's enough. I mean, I'll let other people jump in, but I don't think there's enough evidence one way or the other. But the data, I think it makes sense to look at it every day. That was one study, obviously, right? And in fact, Martin has a paper looking at it on a daily basis, and it looks like it is important, right, on a daily basis.
Yeah. And I like the dynamic driving pressure. Martin Erner says dynamic driving pressure is alveolar pressure with some noise. And with my Italian background, I like the noise very much. Yeah.
So Prof. Vinci and Prof. Abrek, anything to share about this before moving to the next question?
Yes. First of all, I agree with Dr. Slutsky that driving pressure is much more relevant. But what you're really worried about is the energy that's being hit on the lungs to cause ventilator-induced lung injury and the stress and strain characteristics. And regrettably, in most of our patients with ARDS, they have a very heterogeneous lung. And though I'm a big fan of driving pressure, and that's what we measure, at least in my department, which is the largest one in our hospital, the point is that things that can decrease the driving pressure while still maintaining gas exchange are therapies we want to go for. And so I'd like to split that to say that we use driving pressure to set up the ventilator when we go to prone positioning, because in that case you have a much more uniform distribution of the stress-strain relationships within the lung. And it is the disuniformity of the compliance across the lung that's probably one of the major drivers of acute lung injury due to ventilator overdistension. So yes, driving pressure is important, but it should be part of an overall approach to the ventilator management of the patient with severe ARDS, because we're trying to actually not hurt them.
So we'll move to the next question.
Can I make a further comment that in the concept of driving pressure may be challenged in some patients, a third of patients by the findings by Lou Chen and Laurent Brochard and myself, that a third of patients with ARDS may have airway closure that is above the clinical PEEP that is being established, which really mix up the measurement, the understanding of the true driving pressure, distending pressure of the lung. So that not being studied.
Yeah, you need a PEEP higher than the airway opening pressure.
You have to be above the lower inflection point for sure.
Yeah, exactly.
So our next question gonna be, relevant to the earlier question. So the concept of the baby lung and the tidal volume. So is it 6 or 8 ml, or should we even target lower, 4 ml per kg? Should we use intervention maybe ECMO earlier? Because we know, as we said, power and strain, higher tidal volume, more injury. Are we at the stage where we should protect the lung more?
Depends on the patient, right? We thank goodness for H1N1 teaching us that we could actually do ECMO on people and they wouldn't die. because prior to the H1N1 epidemic, we didn't use ECMO very much. And then after that, the good news is that expertise was there when COVID hit. And so there's a lot more understanding at the bedside on how to do ECMO. When H1N1 hit, I had 3 patients in 2 weeks on ECMO, and I hadn't used ECMO in almost 15 years. I'm just saying. And then of course with COVID, with the other problem. But the point is that, as the late Dr. Gattinoni said, the best you can do with severe ARDS is probably to put the lung at total rest. But there is also a complication associated with that. I think with the easier use of peripheral VV ECMO, which tends to work very nice to decrease pulmonary vascular resistance as well and help the right ventricle, we could probably be more generous with the earlier use of it, but there are no clinical trials actually looking at that. And one of the things you don't want to do is put a person with end-stage lung disease who is not a candidate for transplant on VV ECMO and leave them on it for the rest of their life. That would not be a sentence that I would want to give to somebody, even if I didn't like them.
Okay.
You know, I think it's worth thinking about. Your question was baby lung, and should it be 6 ml per kilo, you know, predicted body weight. And I think because it's baby lung, it's ideal to personalize for the patient. Because remember, when we think about 6 ml per kilo predicted body weight, what we're doing is we're normalizing the tidal volume to the patient's normal lung. That's what predicted body weight tells you based on the normal lung, right? When you go back 50 years ago, we used to ventilate patients, and Mike will remember this, based on body weight. So many 10 mils per kilogram body weight. Well, that doesn't make sense, because if someone's very fat, they're still going to have the same size lung. So we thought, so the ARDS had a smart idea, look at predicted body weight, so you normalize to the normal lung. The trouble is for ARDS, it's not a normal lung, it's an abnormal lung. So it doesn't do a great job normalizing for that. What it does help is to normalize to the volume of the baby lung, and that's where, coming back to driving pressure, the driving pressure is normalized to the tidal volume is normalized. So I think driving pressure is actually, again, gets back to your first question, I think makes a lot more sense physiologically. We don't have enough evidence yet, but physiologically makes a lot more sense. And of course, if you can't lower the tidal volume to less than 3, and you're not going to have decent gas exchange, then maybe time to go on to ECMO, to the point that Michael raised.
You walk backwards into ECMO by decreasing the tidal volume to maintain the driving pressure. Okay, if you think about it philosophically, that's what you're doing.
Lorenzo, anything to add about the baby lung?
Yeah, I wouldn't base the decision on going onto ECMO on the tidal volume, but it's a complex decision. The cost of going on ECMO is high though, because it's full of complication. Otherwise, maybe we should start very early, maybe with PF ratio less than 150, for example, which we're trying to study in Toronto in a pilot study. So it's the cost of targeting certain extreme physiologic outcome may be very, very high. So the the judgment of risk-benefit becomes very complicated. Yeah. But anyhow, the OLIA trial, just to add on to this, the OLIA trial showed in the subgroup analysis that the greatest benefit was for patients that were difficult to ventilate rather than the one with severe hypoxemia, just following the concept of lung rest. The big question is that if we believe of complete lung rest, thinking about Luciano, is what is complete lung rest? Should we keep the lung recruited? Should we let the lung de-recruit? Should we give even a small tidal volume or driving pressure or nothing? It's very, there are many questions that are still unanswered.
So we're going to move to our next question, since we're this patient who has ARDS, and then we were at the bedside and we did a proning session. So a lot of people will look at just the BF ratio after proning and then decide whether the proning session was successful or not. And then the next day will come and should we do another session? And how long should we continue proning? So can you let us know, from literature expertise, when do you say a proning session is successful and when do you stop? Do you give them like 7, 8 session, or is it 1 session and then if the PF ratio is fine, then, we move on?
I guess I'll start. So, I don't think there is an answer to that question. Certainly based on evidence, there's not an answer. If you look at the study published in the New England Journal, they checked to see whether when the patients went prone after 16 hours, let's say, per day, if the patient's oxygenation improved in the supine position, PEEP was less tthan 10, and FiO2, I think, was less than 60%, they would say, yeah, we don't have to do any more proning. So I think that seems pretty reasonable, or an approach like that, where you evaluate on a regular basis. But I don't think there's any studies that have shown that there is a correct answer. But that makes sense, right? If the patient is reasonably well oxygenated, and you don't have very high PEEP, and you don't have high FiO2, it makes sense that you possibly don't need it. I'm talking about oxygenation, but of course the main reason for doing the prone is as Michael said, to improve the distribution of ventilation and decrease ventilator-induced lung injury. It's not really the oxygenation, but that's sort of a marker of what's going on.
Right. I was just going to make a comment. I don't think I've ever treated a patient for ARDS in my life. I absolutely have no idea how to treat ARDS. I've supported a whole lot of people with acute respiratory failure due to acute lung injury, which we're calling ARDS, but I don't know how to treat the disease. What I want to do is not hurt the patient while the body itself is trying to recover, while also sustaining as much as possible normal physiologic response. And the advantage of prone positioning, as Arthur said, was that it allows you to use less injury to do it. And when you don't need it anymore because your gas exchange, and the literature shows it's better, that FiO2 is 60% is fine with me. But the point is when they start to look better, you don't need to do proning. But the point is all you're trying to do is not hurt your patient, because we aren't treating ARDS. We're trying not to hurt them while they recover themselves. I think antibiotics, if they have pneumonia, yes, that's a treatment, but that's of pneumonia. So what we're trying to do is prevent further damage and allow the lung to repair.
Yeah, and can I add that, there are some studies suggesting that the response in PF ratio correlates to the outcome of patient, the response to oxygenation after, from supine to proning, but this is not being confirmed by the secondary analysis of the PROSIVA trial by Guerin, clearly showing that the response in oxygenation or CO2 does not predict response, in terms of clinical outcome. So the real question is or the real strategy is aiming at protecting the lung. And if I can add a comment, this is one of the best gifts from COVID, that everyone now is able to prone without any issue. Before we were always saying that to prone someone we need 10 people, 4 to do it and 6 to complain about it, as often said, and now everyone is able to do it with just a blink of eye. So that's a very, very good, because it's a very effective treatment.
Tough way to learn, isn't it? With COVID.
Sometimes, yeah.
Prof. Albrecht, anything you want to share from your expertise?
Yes, on the prone position, I think it's very important to make it for the longest time possible. And the studies that failed to demonstrate an efficacy, the first studies by the Italian multicenter study, failed to have a proof of efficacy because it was applied for a short time. And in physiology, the recruitment is time dependent, and it's important to have a prolonged time of prone positioning, no less than 60 hours. It's an optimal thing. And the PROSIVA study, the French study, showed proved the efficacy of the prone position by applying a longer time than, and including a more homogeneous population of patients, because in some of the RCTs, they included even COPD patients or cardiogenic pulmonary edema. It's important to have patients prone as soon as possible for the longest time possible.
Can I ask a question about in prone position? Do you change PEEP when the patient is prone or not? Because the lung mechanics changes sometimes dramatically. The airway opening pressure changes, the recruitability changes. So should we change PEEP, or should we keep the same PEEP, or how do you manage the
That's a good
PEEP?
question. How do you manage?
It's a real
Well,
debate because
one
there's
of the-
no data.
Okay, one of the things you do, of course, when you put a person in a prone position, you have to support the pelvis to allow the abdomen to fall down, right? There's a whole lot of positioning that's part of it. You put them in a swimmer's position so they're not really prone as such. And so the amount of increase in PEEP that you need is pretty little. The question is, it's to be individualized. And we were bringing the point of PEEP to above the lower inflection point, just simply because we want to keep the lung open with PEEP. But the goal is to protect the lung. And as you said, the outcome is not related to the degree of oxygenation. As Arthur and I remember many years ago when we were residents and fellows in the early 70s, we were trying to increase oxygenation. And we were giving PEEP to get normal oxygens and what we thought were normal tidal volumes. And we were essentially killing patients with ventilator-induced lung injury because we were trying to make them look normal as opposed to allow them to rest. And so the level of PEEP is probably going to be somewhat higher, but won't be done higher if you do it right. And that has to be with the pillows in such a way as to not increase intra-abdominal pressure so that you don't get as much collapse down to the lung.
You know, that's another place where potentially, there's no evidence on this, driving pressure might be useful. You know, set the PEEP to minimize the driving pressure. Makes a lot of sense. Whether that actually works out or not, I don't know, but that makes sense.
Well, would it be acceptable, like when the patient in a prone position to start weaning the vent, like we prone the patient, now PF ratio like 250, tidal volume looking better. Should we start adjusting the vent at this stage or just leave the patient alone till we supinate?
I think you probably want to minimize harm as much as you can. So again, if driving pressure seems like a good way to do that, it's an objective way to sort of measure, and maybe you decrease that, not so much to wean the patient at that point when they're in the prone position, but to minimize the ventilator-induced lung injury.
So how often, Arthur, would you, because I think lung mechanics over a day do change. So how often, if you go on to proning and you see that you finally get the recruitment, the viscoelastic properties don't change immediately, obviously it takes several hours, how often do you reassess driving pressure?
Well, I think it makes sense to do it on a regular basis, but not every hour. You know, 4 to 6 hours, 8 hours, I think would make sense.
Mm-hmm.
Okay, so we'll go
We had, yesterday in the mechanical ventilation symposium, we had a bit of talk about how often a patient on mechanical ventilators should be reassessed. We weren't able to come to a conclusion. I don't know if every second, every minute, every day, every week, if you're lazy.
Yeah. I think in the future, when we have machine learning and artificial intelligence doing it, it'll be every breath. Be assessed every breath, and it will be. I think that's coming.
That's the dream of Marco Ranieri with the stress index.
With the stress index, of course, yeah.
So we'll move to our next question, and I think maybe this is challenging for every resident at the bedside at night. So they get a consult, they admit patient to the ICU, like with a pneumonia, and now when do they intubate? Is it when the patient hypoxic, like the SAT in the 80s? Despite being, they didn't have workup breathing. Like I know in COVID, era, we had many patients sitting in the 80s and they're like talking to us and laughing and they're not even tachypnic. Or should we intubate even though the saturation is fine, but they're like breathing at the rate of 40? So when do we make that decision? I think it's still challenging for me day to day, and we debate sometime around, should we intubate or just wait? Because sometimes, the patient is young, and we said, they will tolerate this tachypnea, but then we have patient self-inflicted lung injury, so what do you do at the bedside? I think in the night when the consultant is not around and the resident is alone.
Well, Arthur brought this up, and that is that there's a lot of options. If you don't have to intubate a person, and you can support them with high-flow oxygen or CPAP, they're going to do better. Laurent Bouchard showed in a very nice study that mortality rate for the same degree of ARDS and sometimes COPD is better if you don't intubate. So I would trial non-invasive quickly, but understand that the reasons for intubation often are airway protection. But as long as a person's conscious, doesn't have secretions, then I can be much more cavalier of trying to use high-flow oxygen and CPAP methods to keep the lungs open if I need that for that purpose in oxygenation. I think we've been taught by COVID that high-flow oxygen, which actually is a form of facilitated diffusion, allows for better gas exchange in those patients too. So the real question is, do they have non-gas exchange causes for intubation? Because if they have those, they need to be intubated, right? If you have airway obstruction, I need to intubate you. I can't not intubate you. And very often, if you intubate a patient, you're automatically put on the ventilator. And that's probably because they're sedated to be intubated. But the question is, to the extent that they have a minimal amount of intubation, ventilatory support for the same gas exchange, that would be good too. So those are my opinions.
But don't you think, I completely agree. Okay, we learned during COVID that even accepting a lower oxygen saturation target is not terrible for the patient. But don't you think if we expose every patient to Optiflow or CPAP, and then we need to intubate the one failing, the intubation becomes much more challenging. So then it depends who's the resident on call at night, you know?
I think the answer is that this is really the art of medicine. And I don't say art because that's my name. It's the art of medicine, because there is no answer I don't think you can give. I mean, you have to look at all the factors, hemodynamics. Is the patient weakening? Are they starting to fail? Do they have a problem with the airway? You know, hemodynamics. There's a bunch of things you have to look at, and I don't think there is any one thing that you could say that don't have to. I agree with Michael that you'd like to delay intubation as much as possible, although, you know, self-inflicted lung injury I think is a real thing, and so if the drive is very high and they're taking very large tidal volumes and you can't decrease that, then that might be a reason. So I really think that's where it's the art of the art of medicine.
Prof. Abrek, anything from, so what do you think? When do you intubate? Do you choose like hypoxia, desat, like saturation in the 80, or you focus more on the work of breathing and how the patient is breathing to decide for intubation?
On what?
Like patient coming with respiratory failure, do you focus more on the SAT to decide about intubation, or you focus more on their work of breathing to make a decision that, you know, this is the time to intubate the patient?
Yes, I think it's important to try to prevent intubation, and for example, the application of CPAP or Optiflow, high-flow oxygenation is correct. It's a good option. So, but in some instances, the intubation is necessary.
The way you've asked the question, it's in a way easy. If the saturation is less than 80, they need to be
Sometimes it's at like 85.
Okay.
And the patient looking at you and he's laughing, and then...
But I think it's usually when they're tiring, you know? I mean, but...
Can I ask, are you proning patient before intubation on Optiflow?
Are you?
No. If I have to prone someone, I can't defend their airway. So I'm very scared about proning a person who's not intubated, unless they're very, very alert, and that's going to be a very unusual patient. Okay, so if I have to prone them, then I would probably intubate them. Matter of fact, let me rephrase that. I've never proned a person who wasn't intubated.
Not even patient with COVID?
I can't hear you.
Not even patients with COVID?
Oh,
because there's pretty good data, not good data, there's some data to suggest that, you know, early, you know, sort of...
or early if they're healthy, and you're just doing it at that point, then it probably doesn't matter anyway, because they're awake. But that's what I said, they're conscious. Okay. The whatever that was called, the happy hypoxia patients, stupid term. But anyway, the point is that they're conscious and they're functional. But when they start getting really sick, I can't imagine that you would try to take a person that's very ill and try to prone them without having a defense of the airway. Now we're talking defense of the airway, we're not talking mechanical ventilation. But you would usually put a person who's intubated on mechanical ventilation. But I'm more concerned in that case with the airway. It's very, the anatomy is not in your favor when you're going into prone position.
Yeah.
So we'll move to our last question. Like everything in medicine, is it the time to use personalized medicine to treat ARDS patient? Again, we said ARDS patient are heterogeneous group. We don't know when we treat them which phase they are in. So how do we excel or improve our patient outcome at the bedside? How can we know which therapy will benefit this patient and which therapy won't?
I don't think we have, in 5 years we'll know, just like the sepsis group said, in 5 years we'll know. You know, I think that personalized medicine, of course, is going to happen. And the truth is, we do that now. When we say so many ml per kilogram, or we say so many ml per driving pressure, that's normalizing to the patient's compliance, essentially, so we're doing that. In terms of other biomarkers, that we're nowhere near that, although it looks potentially interesting. You look at some of the work Carolyn Calfee has done, looking at identifying patients that are hyperinflammatory, hypo-inflammatory. It looks like the hyperinflammatory respond differently to various therapies, so that makes a lot of sense. But no one has done that yet prospectively. There's studies ongoing. If one of those studies turn out to be positive, then I think that'll change and we'll start to use those biomarkers. We're not ready at the moment, I don't think.
Yeah, but the point is that when you talk to the house staff in the hospital in the middle of the night, you have to give them some parameters to start with. And then what you do is you say, all right, start here, and then look at the patient. What is the driving pressure? What has happened to the respiratory rate? What is the gas exchange? And then you titrate that care in a personalized fashion relative to the parameters that you're trying to optimize, which in this case would be driving pressure and PEEP to be at a level of gas exchange. But you have to start with some number. The respiratory therapist is there and saying, what tidal volume should I set on the ventilator, right? And you have to give them a number. You don't say, well, just whatever you want. So you do start with 6 mLs per kilogram ideal body weight simply because it's a starting point. Understanding, as Martin Tobin says, that sometimes it can be larger, but usually it's going to be smaller as they get sicker. And so the point is that you need to have some fundamental guardrails to start, but after that it has to be personalized. And in fact, it usually is. I mean, I don't think we treat everyone as if they're the same. I've never done that. I don't think you have. But you start with some numbers, just to start. And then you see the response of the patient by the measurements, right? So we're all doing personalized medicine.
Lorenzo, anything?
Yeah, I completely agree. We are already doing, and with machine learning technique, we are able also now with the data that we have to understand better the interplay of different variables and understanding if we can identify subgroups that respond better to certain treatment or not. So even targeting, there is a nice paper where they study different target of oxygen saturation. The overall paper was negative, so there's no difference in outcome, but they were able to clearly identify subgroups that based on age and comorbidities were...
No, actually, it's a study by Buell. I'll be talking about it. It's not even subgroups. It's individualized for each patient.
Yeah,
for each individual patient.
Yeah.
And it's a pretty interesting study.
Very interesting study. So we're rapidly going toward that.
So should we use like transesophageal balloon or EIT to help us personalize, mechanical ventilation to our patient? Or I don't think we have
I would
enough.
love for that to work, but it hasn't, and it's something Marcelo Amato's been using for years, the crossover point of hyperinflation versus recruitment that you see with EIT, impedance tomography. It's really neat, but no one's done a clinical trial yet on it. I think the clinical trial is going to be done on that.
There was actually a clinical trial done from China. Ling Liu did a very nice study. No difference using that approach, but in the shrub group of patients who had RI ratios that were high, showed recruitment that looked like there was a benefit. So that may be where you use the EIT might be helpful to try and help you with deciding on the appropriate PEEP, etc.
Okay, then if anyone has anything to add, we'll end up this session and then we'll give some time for the audience if they have any questions. So anyone has any question for our speaker?
There's a question over there.
He's got a question.
How about the smart mode of ventilation, closed loop ventilation in ARDS?
What did you ask?
Did you hear the question?
Closed loop ventilation, like IntelliVent ASV, that may solve the problem of personalizing the management of ARDS?
What did she ask?
So the question was closed loop ventilation?
Loop ventilation.
Yes, closed loop ventilation.
Yeah. Oh, I think we're not using it much in Toronto, but I think, again, that's something that's going to definitely come in with machine learning in the future, that we're going to have closed loop ventilation. By the way, that has to go through the FDA, and in the United States anyway, and through the FDA and get approval, et cetera. But
yeah, but Hamilton has a closed loop ventilator that is approved in Europe, and they're using it for air transport. And it just measures in-tidal CO2 and plateau pressures and looks at the equation of motion to determine the tidal volume frequencies. And we've used it in my lab experimentally. And it works quite well with different forms of lung injury. But it hasn't been, but no closed loop system for ventilation is yet to be approved in the United States or Canada yet. But hopefully it'll be soon, because there's nothing wrong with it. They work just fine. When we gave bronchospasm with methacholine, it immediately adapted. You know, so the closed loop systems look like they work well. And I think it would be a nice way to start, especially for transport.
Alberto?
Great session. Question regarding like fashion, right? Steroids. Over the course of the year, we've seen different approach in the ARDS. And again, COVID gave us some insight on use of steroids in patients with COVID pneumonia. What about ARDS? I think is that the ATS document gave some conditional recommendation for the use of steroids. I think there is ongoing discussion in my group, for example, about using steroids. What is your take on steroids ARDS?
Yeah, I can answer it. So I think there is equipoise still about the use of steroids in ARDS, and then depends on the cause of ARDS, of course. So for COVID, we know the evidence is strongly supportive, the use of dexamethasone. For community-acquired pneumonia, hydrocortisone, according to the French studies, improving outcomes. But for all the other causes of ARDS, there is huge equipoise. So that's why we're doing in Canada as part of the practical platform trial, the CORDI2 trial, where we really try to answer this specific question. So early use of dexamethasone in patient with the ARDS, not from COVID or community-acquired pneumonia, and extend the use. Because the other question is, how long should we, if we use steroids, how long? Should we use for 10 days, like in COVID? If the patient is not recovering, should we use it for another 10 days? So what's the optimal duration? So this CORDI2 trial will, I think, conclusively, hopefully,
I think
answer
that this is an excellent example of the fact that ARDS is a syndrome caused by many processes, and COVID being a very specific endotheliopathy that causes the dysfunction, the loss of hypoxic pulmonary vasoconstriction, the acute kidney failure, et cetera, is an example of where there may be selective use of steroids that will be more efficacious, whereas in other conditions it may not be.
Yeah, absolutely.
Jesus Villar had a study, right? Jesus Villar, Lancet Respiratory Medicine, that looked like it was positive, you know, in sort of general ARDS. So, but it's not definitive.
It's not definitive. It's multiple sites.
We have one last question.
Thanks for an excellent debate. Just a question. As an anesthesiologist, we work with normal and sick lungs in the operating room. Should you use lung protective strategies even in a healthy lung in the operating room, or should we just stick to normal tidal volumes?
The answer is you should use driving pressures and small tidal volumes, even for short periods of time. There's been very nice studies showing that large tidal volumes, even for a short period of time in the operating room, is associated with increased injury mortality. And so the answer is that there's nothing special about surgery that allows you to get away with something you can't do in the ICU.
Excellent answer. Thank you.
Thank you so much. I think we have had our last question. Now we're going to have a break till 9:50. Then we're going to come back with more interesting lectures and topics.